We're going to start a minute or two early, and I've been promising this presentation since early this morning. The presentation is entitled Building Better Recommendations using a different tool that we developed at Yale called Bridge Wiz. Bridge Wiz stands for Building Recommendations in a Developer's Guideline Editor, Bridge, and then Wiz. It's a wizard application, and for those of you who are familiar with many of Microsoft's educational tools, it's an application that takes you step by step, systematically and linearly through a process of doing something. Some essential background, first of all, a rationale. Why did we think that software could help in building recommendations? Again, what constitutes what we think is an ideal recommendation. And then I'm going to introduce two concepts that you're probably not familiar with that will help to understand how Bridge Wiz works. One of them is the concept of action types, and the other is level of obligations. So, key action statements or recommendations, and we've taken to using both of those terms to refer not to guidelines, but to those pieces of guidelines that tell people what to do. These key action statements differentiate guidelines from other publications. Systematic reviews ideally shouldn't contain recommendations. They ought to be all the background, all the evidence, but they shouldn't take you to the point where you actually tell people what to do. However, shortcomings in guideline recommendation writing lead to difficulties in implementation. As we said earlier today, recommendations are often vague, underspecified, or frankly ambiguous. There is regularly an unclear linkage between a recommendation and its supporting evidence, and the expected level of adherence, the recommendation's strength, is often not explicit. This happens particularly when panel members are chosen up for an ad hoc guideline development process, as opposed to seated bodies of guideline developers like they have at the American College of Physicians or the Preventive Services Task Force, who do nothing but write guidelines on multiple topics. But when you assemble a group of panel members who are subject matter experts, they're often unfamiliar with recommendation building. Bridge Wiz offers a systematic and replicable approach to creating recommendations. So, that doesn't want to go. There we go. You saw this slide earlier. I may show it even more times. Authors should be explicit about when, that is under what circumstances, who in the intended audience ought, with what level of obligation, and we'll talk about that in just a moment, to do precisely what to whom, and then to make sure that each recommendation is associated with a how and a why. You'll recall that the Institute of Medicine asked us to provide all of this information about each recommendation and all of this information about articulated recommendations. So what's an action type anyway? Several years ago now, two of our fellows looked at a large number of randomly selected guideline recommendations from the National Guidelines Clearinghouse. There were close to 1,200, I think, by the time they were done. And they found that guideline recommendations did not call for people to do an infinite number of things, that there were, in fact, about 14 categories of things that guidelines ask you to do. They ask you to gather more data, to do a test, to monitor a patient, to inquire about something, or to examine in a certain way. They tell you to come to a conclusion or a differential diagnosis, come to conclude, or to perform some activity like to prescribe a drug, perform a procedure, educate or counsel a patient, consult or refer to a colleague, document in the record, advocate on behalf of your patient, prevent, prepare your facility in some way, or dispose of a patient in a particular way, usually by admitting or discharging or changing to a different level of care. Now we have, I believe it was Larry Pickering, who looked at a whole series of recommendations for the kinds of verbs that people were using to tell them what to do. A recommendation is not contraindicated. Patient may benefit from, may be beneficial, will benefit from. It may be helpful. Most experts recommend, some experts recommend, some experts suggest, some experts prefer, some experts consider. Experts differ in opinion. The manufacturer recommends. This is a lot of different ways to try to indicate a strength of recommendation. And I'm not sure that any of those constitute the best way to convey that information. So one of those two fellows I mentioned did a study, an online survey of registrants to the annual meeting of the Agency for Healthcare Research and Quality. And he presented them with 12 statements that were of the form, if the patient has condition X, clinicians must prescribe drug A. If the patient has condition X, clinicians must consider prescribing drug A. If the patient has condition X, clinicians should prescribe drug A. And participants were to use sliders, and I guess I can slide better with this, to indicate the level of obligation they believed that the guideline authors intended, somewhere between full obligation and no obligation. And what he found was that it was possible to rank these terms in descending order with greatly overlapping interquartile ranges, but it was also possible to simplify this to 3 non-overlapping levels of understanding. There is a must obligation to this group of people was different from a should obligation, which is different from a may obligation. And to the extent that this represents empiric evidence that people can differentiate 3 levels of obligation, this is one of the faults that we see with grade, because you get only 2, strong or weak grade. Musts are really very uncommon. Out of 1,250 recommendations, only 19 were musts. They were things like narcotic use must be carefully titrated and supervised. Clinicians working in juvenile justice settings must be vigilant. Nurses working with individuals with asthma must have appropriate knowledge and skills. I have some trouble with this last one. Treatment of duodenal adenomas depends on adenoma size and the presence of severe dysplasia. Small tubular adenomas with mild dysplasia can be kept under surveillance, but adenomas with severe dysplasia must be removed. There may be some people, maybe a 90-year-old, for whom must suggest that it's pretty much appropriate for everybody, and I'm not sure that's true, at least of the last one. So bridging the gap between guideline authors and implementers using Bridge Wiz. The intent with Bridge Wiz is to have your guideline development panel sitting around a table, and the program is projected on the screen at the end of the room, much as we're going to set up a little later today. And the example that I'm going to use is something that actually came out of a guideline development effort. At one point, they had the general idea that metformin ought to be first-line treatment for kids who have newly diagnosed type 2 diabetes, along with diet and exercise. That was the content that they were trying to build a recommendation around. COGS opening screen invites you to do one of 2 things at the bottom. I'm sorry, Bridge Wiz opening screen invites you to create a COGS statement, the Conference on Guideline Standardization, or to begin creating a key action statement. Looking at the COGS statement, first of all, it is a listing of 18 criteria that we came up with at Yale in 2003. I mentioned it quickly this morning. These criteria help to define guidelines that are of high quality and high level of validity and implementability. They help guideline development teams to make sure that they have included answers to all of these questions, but probably you don't need to go through this entire checklist at the beginning of a guideline development effort. It is helpful, though, to describe the intended users of the guideline and describe the patient population eligible for guidance, and perhaps to talk about specifically what are the goals of writing this guideline. Those three things, a general discussion before you start writing recommendations can be quite useful. So now we step back and we're going to start building a recommendation about that metformin prescription. And it asks us to decide what type of activity are you proposing. And that activity was talking about starting metformin, about prescribing a medication. So we click prescribe, and in fact, that is one of the choices. Based on the prescribe action types, we have a whole list of verbs that go with it, and these are transitive, active voice verbs, from which we can choose the verb start because they had thought that starting metformin was a good thing to do. Bridge Wiz next asks, first it asks what type of activity do you propose? Based on the prescribed action type, select a verb. Start what? Start metformin as first-line treatment. So we're getting out of the way what the recommendation is telling you to do. And you'll recall that there was an and, that they recommended that we recommend diet and exercise. So we choose the action type educate counsel. Under that action type is the recommend verb. Recommend what is diet and exercise. And this gets us to a compound activity that is being recommended. Bridge Wiz next asks about its executability. Is each recommended action stated specifically and unambiguously? That is, would members of the intended audience execute each action in a consistent way? If not, rewrite it. Start metformin as first-line treatment. That was pretty clear to the group for whom they were writing recommendations. Recommend diet and exercise, however, they realized was very vague. Recommending diet and exercise is not likely to make much of a difference in your life. But they wanted to make a straightforward, bold-faced statement. So they left it this way with a note to themselves that the text that accompanies recommend diet and exercise would really need to beef up exactly what how and why, of course, diet and exercise are considered to be important. The next step is to answer the question, under what conditions will starting metformin as first-line treatment and recommending diet and exercise be performed? We have input from all the folks around the table. Under what conditions? Well, they decided if you were newly diagnosed with type 2 diabetes, then starting metformin would be the way to go. And there's no ands, there was only a single condition. Would the guidelines' intended audience consistently determine whether each condition has been satisfied? Newly diagnosed with type 2 diabetes. As they thought about it, they agreed that newly diagnosed was a little vague. How do you know if you're newly diagnosed with type 2 diabetes? So they clarified it, and they put in a clause, you're newly diagnosed if you had not been previously treated for diabetes. We're next asked to describe the benefits of starting metformin as first-line treatment and recommending diet and exercise if you're newly diagnosed. And this is a place where everybody in the room starts shouting out a benefit. You'll lower the hemoglobin A1C. The target A1C will be sustained longer. There's less early deterioration of blood glucose. Lower chance of weight gain, improved lipid profile. All of these are things that are likely to get better if you do this. What are the anticipated risks, harms, and costs, though, of starting metformin if you're newly diagnosed? Well, in fact, there are GI side effects to metformin. There's a rare potential for lactic acidosis B12 deficiency. We have the cost of medication and its administration. We have to do self-monitored blood glucose, et cetera, et cetera. We make a list of the benefits, the list of the harms, and then we ask the hard question, and this usually engenders considerable discussion. Is there an equilibrium or a preponderance of benefits or risks, harms, and costs? We list again the benefits. We list again the risks, harms, and costs. We recognize that it's not the number of these things. It's the likelihood of their occurring and their impact, if they occur, that needs to be aggregated. And this is something that all comes ideally from our evidence review, from our systematic review of the evidence. We know how effective we're going to be at lowering hemoglobin A1C, and we know about this potential risk of lactic acidosis. And this is not a mechanical judgment that is made. This is that judgment that is attended by values, but somebody that makes a decision, or hopefully the group comes to consensus, that there's a preponderance, in this case, of benefit. We next ask, what is the aggregate evidence quality that supports these benefits, risks, harms, and costs? And we display for you the evidence quality rating scale that's in use by this particular organization. So it's different for different organizations. You're looking at the AAP scale. They have grade A, B, C, D, and as I mentioned earlier, grade X evidence. The best they were able to come up with respect to starting metformin in kids, was that this is grade C evidence. And grade C allows you, when there's a preponderance of benefit or harm, to have what the American Academy of Pediatrics calls a recommendation level recommendation, to a strong recommendation, or what they are currently, but not for long, calling an option. So based on the quality of evidence grade C, a preponderance of benefit, this key action statement can have a recommendation strength of recommendation, and the level of obligation should be a should. We have a mapping for each of these terms to a must, should, or may. This is the system in use by another specialty society, and another specialty society, and yet another. And I guess I thought I had included grade, but I guess I didn't. Right now we have, how many, George? 6? About 6 different organizational quality rating scales and mappings between recommendation strength and terminology. The next question is, who's supposed to start metformin as first-line treatment and recommend diet and exercise if you're newly diagnosed? Who's supposed to do this? The answer for this group is clinicians. Sometimes it'll be patients. Sometimes it may be paraprofessionals. In this case, and in many of the cases that we work with, it's clinicians. And then we ask that you choose a recommendation style. Rather than forcing people into a shoehorned approach to a single way of expressing recommendations, we give them 4 ways to say exactly the same thing. If you're newly diagnosed with type 2 diabetes, then clinicians should start metformin. Clinicians should start metformin if you're newly diagnosed. The American Academy of Pediatrics recommends that if you're newly diagnosed with type 2 diabetes, then they say exactly the same thing, but they say it in slightly different ways. Once you select these, or one of these, you're able to edit it so that the lack of English that may be injected by the computer comes out. And you are left with a key action profile for each recommendation that reminds you how this recommendation was put together. You get, as a Microsoft Word document from Bridge Wiz, a document that can be further edited, the key action statement, the if-then, the aggregate evidence quality, the list of benefits, the list of risks, harms, and costs, the benefit-harm assessment. If there were value judgments that went into it that you want to be transparent about. Here's a place that reminds you to insert them. If there was intentional vagueness that was injected, why was it injected? Is there a particular role for patient preference here? Are there any specific exclusions from the target population? So, Bridge Wiz formalizes a process for writing implementable recommendations. It helps to focus the discussion. I'm sure those of you who participate in guideline development efforts know that these discussions can become quite tangential. And the cure for that is for somebody in the group to point to the front and say, this is the question that we should be trying to answer at this point. It incorporates prompts based on the Conference on Guideline Standardization. If you answer all those questions that we showed up front, it'll help improve guideline quality. It uses controlled natural language, informatics term, which offers verb choices based on action type. If we had tried to use the word consider, we would have had our hands slapped. It discourages statements of fact that masquerade as recommendations because it tells you these recommendations are about things that have to be done. It limits Boolean connectors to all ands or all ors in a statement, or at least on a line in a statement, because as you remember from this morning, mixing your ands and your ors may get you an ambiguous statement. It incorporates decidability and executability checks that come from GLIA. It requires a systematic appraisal of evidence quality and benefits and harms, and suggests an appropriate obligation term. The output includes a high-level if-then rule, as well as that key action statement profile. Number of organizations are using or have tried out Bridge Wiz. The four on the left are the ones I mentioned this morning. They have each made it a part of their routine guideline development process. I honestly don't know where things are with these groups. We have sent them copies of Bridge Wiz. I've gotten some feedback, but I don't know whether it's been integrated. We took the first 69 folks who I think served on 5 different panels and gave them a survey about what they thought of their Bridge Wiz experience. The first question was, on a 1 to 10 scale, how useful was it? And they gave us an 8 with an interquartile range of 7.5 to 9. And then we asked a whole series of complicated questions. And the best way to appreciate or not appreciate this chart is to know that dark green and green are agreeing with the statement on the left. Yellow is indifferent, red is disagreeing. And agreeing with the statement is generally a positive thing for people using Bridge Wiz. So for example, the listing of verb choices based on action types is useful. We had overwhelming dark green and green support for that. You can see that there was very little disagreement, and it actually had a blue category for people who strongly disagreed. In that first 70 people, nobody strongly disagreed with statements about Bridge Wiz improves the quality, clarity, transparency, implementability, and the development process as a whole. And I guess, so this is going to be the statement that we're going to Bridge Wiz-atize in a little while. So the floor is open for comments on Bridge Wiz and whether this may be part of an answer for CDC. Yes. So the comment we have is it could be helpful in dealing with disputes between methodologists and subject matter experts. Subject matter experts often trying to trump the guideline methodologists who really know what a guideline ought to look like. And the fact that the advice or the assessment is coming from a non-human may make it even more useful. Yes? You have to choose one. So the question is, how do you get to the aggregate of evidence quality when you have varying levels of evidence quality? You obviously, I think, want to choose the highest applicable level. So if you have a couple of good randomized controlled trials and observational studies, the randomized controlled trials are probably going to trump it. On the other hand, if there are weaknesses in those trials, they're going to mark it down. And this is one of the places where I think grade has been particularly helpful. The idea of up and down grading evidence as we try to arrive at an aggregate level. Okay, well, you need to get across studies. And the question is, how do you do that? One pretty good study and a whole bunch of low level, is that something you're immediate, or is it's a tough question, and it's a question particularly for the methodologists at the table. In general, the subject matter experts are interested in upgrading things. They would really like to make strong recommendations, and sometimes they have to be reined in. I say this, and I think back on my most recent experience, and it's really been the subject matter experts who've been holding us back a little bit and wanting to downgrade recommendations, but that may not be universal. So the question is, can you plug in alternative recommendation grading systems into Bridge Wiz? And the answer is yes, to some degree. You have to. What we do right now is we have a data collection form that we send out to people who have expressed an interest in Bridge Wiz. And on that form, we ask them to give definitions for each of their evidence quality categories, give definitions for each of their recommendation strength categories, to relate for each when there's a preponderance of benefit or harm, or when there is an equilibrium between benefit and harm. That's sort of a minimum. If people haven't done that, and they also need to come up with an appropriate obligation term that goes with each recommendation strength. A lot of organizations don't have that. They don't have clear definitions. They don't recognize the difference between evidence quality and recommendation strength. It's all grade A, and they don't know the difference. In that way, we've found that Bridge Wiz is already beginning to influence people to have two different rating schemes, because in order to use the system, they have to come up with definitions and relationships and obligation terms. For organizations for whom that isn't true, at this point we tell them we're unable to use Bridge Wiz, but we've been able to do it 8 times. 8 times. So George has 8 different systems that are available, and we continue to be open, at least temporarily, to the idea of adding additional systems, but those systems have to conform to what the IOM says is the right way to be doing things. It's paternalistic, but it seems to work. All right, well, let's see if I can restate that. This gets again at the question of, are public health guidelines different? And certainly they refer to different subject matter, different realms. But the points that you made are that there often isn't good evidence. And I think often not having good evidence is something that is shared very much with clinical practice guidelines. I'm not sure that things are fundamentally different. Also shared is the fact that there are certain circumstances when certain interventions are appropriate. They may be public health interventions, they may be community-oriented interventions, but they are still interventions that are appropriate under certain circumstances. So that's my informatics side, trying to turn everything into an if-then rule. To the extent that you can turn it into an if-then rule and then be transparent about the fact we really don't have good evidence about this, I think Bridge Wiz and this approach can be used. It's painful to have to admit we don't have good evidence about this, but it's useful to people who are going to implement your programs to know that this is the opinion of some very smart people at CDC, not substantiated by peer-reviewed evidence. Well, screening isn't always a good thing. No. Tamara was saying that sometimes we know the what, but the how and the why, the how we don't know, the what we know to be effective, at least in many circumstances, but we don't know in a particular circumstance. We have strong opinion, we have good opinion, we have smart people who believe in this. My response to that is, if you don't have the evidence, you don't have the evidence. Screening is a good thing. Screening 40-year-olds for breast cancer may not be a good thing. Screening 75-year-old men for prostate cancer using PSA may not be a good thing, even though screening in general helps to identify disease at a time when it is potentially curable. Under certain circumstances, it isn't the best course of action. So my thought is that even though screening is a good thing, screening for a particular thing is what you need to justify. And you need to either have the evidence, screening for what? Screening for breast cancer in 60-year-old women is a good idea. And we have good evidence to support it, but screening for breast cancer in 20-year-old women as part of a screening effort and population-based probably isn't. Right?
Hello?
Well, you can not only talk about the what, if there are different studies that are out there, you can talk about the how. You can say that this worked in a population similar to the population we're making recommendations for, or this worked in a population very different from our population, a disadvantaged population in downtown Chicago, and we're trying to put it in a school in Massachusetts. We think it'll work. We have good reason to believe it'll work. It worked in this one circumstance, but the applicability is weak, and we have to downgrade the strength of recommendation because of that. So Tamara continues to try to convince me that this isn't a matter simply of evidence and applicability. And I hear what you're saying, and I think there is a piece of this, but I'm not sure how best to carve it. Jeremy has his hand up. So Jeremy has divided this into two recommendations at different levels. If you are going to open a conflict resolution program, you may be able to say, if the school, what's the if side? If you have kids who need conflict resolution, this conflict resolution program has been demonstrated to be effective with high quality evidence. Then, so if you've decided to use a conflict resolution program in your school, then there are program X, which has moderate level of evidence behind it, program Y, which has poor level of evidence behind it, and method Z, which also has low level of evidence but seems to make sense. So Tamara says we're still struggling with the how. This is good for the what. If P, then Q. Q is what, because that's the why. And then the how is still to be determined. And the how is something that is very case specific. Yes. So it's being pointed out that the how is often clarified in the methodology section of the studies that demonstrated effectiveness of the program initially. The best practices exist.
The conference is now in silent mode.
The conference is just in silent mode, they told me. What does that mean? Ah, okay. It's a good thing I understand now everybody is properly muted. But I lost my train of thought, unfortunately. So best practices, professional standards, these are often synonyms for things we expect are the right thing to do, but there just isn't great evidence available. These are things that probably represent the way things should be today, but we shouldn't make them a legal standard. We shouldn't make them a performance-measured standard. We shouldn't make them something for which you will be chastised if you don't adhere. These are our understandings of the best way to do things 2013. This question of what to do under circumstances of low-level evidence is really still a big problem for us guideline methodologists. I don't think we have answers for this that are effective and universally applicable. I'm sorry. Well, these terms mean something. The question is, because CDC is a federal entity, the terms must and should have implications that we may not want to get into. This is also an issue that every entity that makes guidelines has to deal with. And so long as you're very clear about what must, should, may, suggest, mean, I think, again, it's a matter of transparency. You want to be able to differentiate different levels of intended adherence. And there are some things like you need to be vigilant if you're handling narcotics in a prison setting. I don't know why that couldn't be a must, even from a federal standpoint. But the key thing is to be very clear on what the expected adherence is to a must, a should, a may, or whatever other terms you choose to use. These terms, they've also done similar studies now in France and Germany. They have the same issues with the modifiers and not wanting to be too strong, but wanting to be strong enough. We also have the issue about when it's a not recommendation, when you're telling people not to do something. Must not is a parallel to must. Should not is probably a parallel to should, but may not does not reflect accurately a may. It doesn't fit, and we don't have a good choice at the bottom there. So does GLIA complement Bridge Wiz, or is one or the other? And is there some sequence to how they should be used? They are certainly complementary to a degree. You see that the decidability and executability checks are in Bridge Wiz. So we have a little of GLIA in Bridge Wiz. You don't have very much Bridge Wiz in GLIA, but you have a much more in-depth look at issues in finding obstacles, to implementation. I don't know that there's an optimal sequencing. Right now, the American Academy of Otolaryngology, again, is using both. And Bridge Wiz is used earlier, at the time you're trying to first make recommendations. GLIA is a little bit later in the process, I think, when recommendations have been made, but they're not hardened into stone, hardened into concrete, hardened into, what do we harden?
Okay, thank you.